Name XYZ, aged 42-year-old male, bank employee by occupation, residing in Bangalore. Date of admission was on 7th May 2021 and date of examination on the same day, 7th May 2021. Coming to the presenting chief complaints, patient complained of difficulty in lifting both the arms above the head. Coming to the history of presenting illness, patient was apparently well till 9th standard. He was a sports person who used to initially come first in running race, then started coming fourth. He noticed that there was difficulty in raising both his arms overhead persistently, insidious in onset, gradually progressive in nature. He also complained of difficulty in reaching higher objects and combing hair. However, the weakness had no diurnal variation to cold, temperature, or exercise. Patient could, however, unbutton his shirt, mix food, could open a bottle cap, and grip smaller objects in his hand.
Continue.
There was no complaints of weakness in both lower limbs. He could get up from sitting position, he could climb stairs, and he could grip the chappals. 10 years back, patient noticed that he could not whistle and there was an abnormal flattened smile. He also complained of difficulty in complete closure of both his eyes. At the age of 21, he noticed that there was difficulty in folding both his arms at the elbow joint. Patient had no history of any bowel or bladder disturbances. There was no history of suggestive of any sensory disturbances. There was no history of stiffness of the limb, no history of twitching or fasciculations. Patient did not complain of difficulty in lifting his head up above the pillow, turning side to side on the bed, or getting up from the supine position. Patient did not complain of any cervical or root pain. There is no history of drooping of eyelids, no history of double vision. There was no history of difficulty in swallowing, dysarthria, or nasal regurgitation of the food contents. There was no symptoms which were suggestive of hypothyroidism, hyperthyroidism, and Cushing's disease. There was no history of carpopedal spasms, no history of bony pain, no history of excessive daytime sleepiness, no history of brownish discoloration of urine. Patient did not give any history of involuntary movements of the limb, no history suggestive of any cardiac involvement like chest pain, palpitations, swelling of bilateral lower limbs, breathlessness, or syncopal attacks. There was no history of cramps, no history of contractures or pain. There is no history of cognitive disturbances. There is no history of any other respiratory failure symptoms, cardiac failure symptoms, or liver failure symptoms.
Next slide.
Coming to the past history.
Yeah, we'll go to the past history later. You come to the first slide.
Yes, sir.
Yeah. So the second, yeah. So the chief presenting complaint, he came to the hospital with a difficulty in lifting both the arms above the head. That was the chief complaint.
Yes, sir.
Then come to the history of presenting complaint. Right now, the patient is 42-year-old. And when he was in 9th standard, he noticed that he used to come first in running race. When he came to 9th standard, at that time he started coming fourth. He was a sports person, what he told.
Yes,
so running race, he used to come fourth. So that was the first sign of some abnormality in any weakness he noticed. At the same time only he told he noticed he couldn't, there was a difficulty in raising both the arms above the overhead.
Yes,
so that indicates proximal or distal muscle weakness, upper limb, difficulty to lift the arms above the head.
Proximal, sir.
Proximal. So proximal weakness at that time he noticed. And according to him, the weakness was persistent. So there is no intermittent weakness. Because in any muscle disease, the basic approach only will distinguish. The first step is whether the weakness is intermittent or persistent.
Yes,
because there are some diseases which will have intermittent weakness, some muscle diseases which will have persistent weakness. That is the first question what you asked, persistent weakness that was.
Yes, sir. Yes, sir.
And it is insidious onset and gradually progressive because there are some muscle diseases which will be acute onset.
Yes, sir.
Can you tell some of the diseases, muscle disease where there is to be acute onset, only motor involvement, acute involvement?
Usually hypokalemic.
Very good. Periodic paralysis is one. Periodic paralysis will be acute onset. Any other disease around days, hours to days, it can develop the weakness. Only motor weakness. Only periodic paralysis is very good. Then
GBS syndrome.
very good. Guillain-Barré syndrome. Similarly, like acute intermittent weakness, any other disease need not be a motor anatomy. It could be a neuromuscular junction.
It could be myasthenia gravis also.
Myasthenia gravis. Okay, there will be usually acute onset with the weakness.
Yes,
but here the weakness is insidious onset and gradually progressive. Yeah, okay. Then you complaint of difficulty in reaching the higher objects and combing the hair. Again, that indicates a proximal muscle weakness. Difficulty in reaching the higher objects in the upper limb.
Yes.
When you are asking weakness has no diurnal variation. Why you have diurnal variation?
Diurnal variation usually in myasthenia gravis.
Myasthenia gravis, very good. Then you also ask variation to the cold temperature and exercise. This particular history, the weakness which will vary with the application of a cold or which will worsen with exercise, where you get that?
In paramyotonia.
Paramyotonia congenita, the weakness will worsen with cold and also with the exercise. Okay. Then you are told there is you could however button, unbutton his shirt, mix food, open a bottle of tap, and grip objects in hand. So all these symptoms, why you ask in the history in the upper limb?
To rule out distal muscle involvement.
To rule out distal muscle involvement, you ask these symptoms. Good. So patient doesn't give history of any distal muscle involvement in the upper limb. So from 9th standard till now also there is no distal muscle involvement at all.
Yes.
Only upper limb proximal only involved. Even now there is no distal muscle involvement in the upper limb. Okay, next slide. There is no complaint of weakness in both the lower limbs. Symptom wise, there is no weakness. You are telling there is no symptoms suggestive of in both the lower limbs. You could get up from sitting position, climb space, and grip the chappals.
Yes, sir.
Sitting up standing from a sitting position and climb stairs is a proximal or a distal muscle weakness.
Proximal, sir.
Proximal, and could grip the chappal, that is distal muscle weakness. So lower limb, there is no weakness of either the proximal or distal muscle weakness. Okay.
Yes, sir.
10 years back, that is when he was 32-year-old, he noticed, you are told he couldn't whistle and there was an abnormal flattened smile.
Yes, sir.
Okay. That indicates what? Couldn't whistle.
To rule out any facial muscle
facial muscles weakness. Facial muscle weakness. Those, that is why he couldn't whistle. He has also complained of difficulty in complete closure of both the eyes. Again, that indicates upper facial muscle involvement.
Yes, sir.
Okay, so that is his complaint 10 years back when he was 32-year-old. Okay, so classically he is saying there is a facial muscle weakness and there is an upper limb proximal muscle weakness. Till now, that is a complaint. Then at the age of 21 years, that is around 20 years back, he noticed there was difficulty in folding both the arms at the elbow joint. Okay. Then you ask any history of bolum bladder involvement. Why you ask history of bolum bladder involvement in this case?
Sir, later stages of cervical myelopathy can present with bladder bowel involvement.
Yeah. So bolum bladder involvement, it localizes anatomy, which structure, where you localize if there is a bolum bladder involvement.
Any myelopathy, spinal cord.
Spinal cord. Spinal cord, it localizes bolum bladder involvement. So whether this motor weakness is due to the spinal cord involvement, to rule out that, you ask here bolum bladder involvement. Nice, very good. Next slide. No history of sensory disturbance. Yeah, so here only few motor weakness is saying there is no history of sensory disturbance. So you asked how for the sensory symptoms, how you asked in the history, for fine touch, how you asked, for pain and temperature, how you asked in the history.
So usually we ask that history. So for positive paresthesias and negative. In positive paresthesias, burning pain, then any pins and needles sensation.
And that's a peripheral neuropathy symptom.
Yes, sir.
For a sensory disturbance in the body, how you will ask in the history for a fine touch, how you will ask for a pain and temperature. History wise, how you will ask. For a fine touch, you will ask whether you can appreciate any cloth on the body.
Yes. Yes.
If you appreciate the cloth on the body, that is a fine touch. Whether if you can appreciate while taking bath, hot and cold water, that give a clue whether pain and temperature you can appreciate or not. Hot and cold water during bath. These are you have to ask for a sensory disturbance. Okay.
Yes.
Yeah. Then next you ask no history of stiffness, twitching or fasciculation. Why you ask stiffness history?
Stiffness, again, to rule out any UMN lesion, sir. For
Yeah. So
example,
corticospinal tract involvement to rule out your history of any stiffness, corticospinal tract involvement. This motor weakness, whether due to corticospinal tract involvement to rule out that your stiffness is stiff. Then twitching and fasciculations, did not all the patients notice it. It may be a sign, but some patients, they may, if there is extensive fasciculation, they may complain, they may come to a doctor with that. Which disease you are thinking, fasciculation and twitching?
again, ALS, sir.
ALS. ALS, there will be a fasciculation and twitching. So thinking that you ask that history, the motor weakness, whatever he is having, could be because of ALS. Because of that, you ask that history. Okay.
Yes.
No history of difficulty in lifting his head up above the pillow, turn side to side, or getting up in supine position. Okay. Getting head up above the pillow, that is neck flexor muscles, turn
Yes,
side to side, truncal muscles. Thinking that you asked that.
Yes, sir. Yes.
Okay. You asked no cervical or root pain. Why you ask that is root pain or neck pain?
Sir, again, in upper motor neuron lesions, they can present with
Where you get root pain? Where you get root pain?
root pain, usually radiculopathies.
Where you get that? In which disease? Root pain.
In cervical myelopathies.
Compressive. Compressive myelopathy.
Compressive.
See here, there is a weakness of the upper limb, predominantly upper limb. Then bilaterally symmetrical you are telling. So whether any compression at that level. Usually if it is a compression, the weakness won't be symmetrical. It will be asymmetrical onset. One side it starts. Any the motor weakness or any sensory disturbance in a compression, it will be asymmetrical and there will be a root pain. So to rule compressive myelopathy, you ask this. The cervical or a root pain, the neck pain or a root pain. Okay. Then next you ask no history of drooping of eyelid or diplopia. So eye involvement, you ask for a drooping of eyelid or diplopia. Thinking what, which diseases you ask this drooping of eyelid and diplopia?
So usually oculopharyngeal muscular dystrophies, then progressive external ophthalmoplegia.
Mitochondrial myopathy.
Yes, sir. Myasthenia gravis also can cause.
Myasthenia gravis also. Okay. Yes. What is the age of onset you are thinking oculopharyngeal? What is the age of onset oculopharyngeal?
So usually in the early 20s.
No, late. It's a late onset. It will come in 4th decade, 5th decade, oculopharyngeal. They'll have dysphagia along with the doses. The name indicates oculopharyngeal, pharyngeal dysphagia, ocular involvement. The arm involvement, leg involvement is very mild. It won't be every man, very severe like this in this patient.
Okay, sir.
Then diplopia, thinking myasthenia gravis you are asking, but it still is only says it's a persistent weakness. There is no intermittent weakness, but still to rule out, you are asking the history for a completion purpose.
Yes.
Okay. Okay, right. Any other disease you get ptosis, so with the distal muscle weakness?
Sir, even myotonic dystrophies.
Very good. Myotonic dystrophy also you get ptosis with a distal muscle weakness. Distal muscle you get. So thinking that you ask those points. Next point.
No history of dysphagia, dysarthria, and nasal regurgitation, sir.
Where you get which muscle disease will have dysphagia, dysarthria?
Usually mitochondrial myopathies like.
No, this oculopharyngeal you told, no, that will have dysphagia. Oculopharyngeal muscular dystrophy will have dysphagia. Mitochondrial dystrophy also because of the involvement of palate, pharynx, you may get a dysphagia and dysarthria because the tongue involvement, palate and pharyngeal involvement, you may get dysarthria and dysphagia. So thinking that probably you are asked that symptom. Okay. Then next you are come to the endocrinological symptoms, hypothyroidism, hyper and Cushing's. Why you ask all those things? Hypo and Cushing's symptoms.
All these conditions are again associated with proximal muscle weakness, especially iatrogenic steroids. It can cause proximal myopathies.
Good. So all the endocrinological disease what you have mentioned here can produce proximal muscle weakness, what this patient is having. So to rule out, you ask all these endocrinological symptoms. Okay. Next slide. No history of carpopudal spasm and bony pain. Why carpopudal spasm? Why bony pain?
There are hypocalcemia due to hypoparathyroidism can cause.
Again, they can have proximal weakness. Okay. Bony pain.
Bony pain again, osteomalacia. Second to
osteomalacia will have bony pain. They'll have proximal weakness. Okay. Good. Yeah. Next question. No history of excessive hypersomnia. Which muscle disease will have hypersomnia?
There again, usually myotonic dystrophy can cause.
Myotonic dystrophy, they'll have hypersomnia. Okay. Then you ask no history of Browning's discoloration of the urine. Why you ask that history?
Sir, usually myoglobinuria due to toxins and glycolytic defects, fatty
Like
acid
that. Very good.
metabolic disorder.
Very good. Right. So toxin induced myoglobinuria, statins. So thinking that you asked that history. So okay. They will have severe pain usually. Okay. The muscle pain.
Yes.
Okay. Right then.
No history of involuntary movements of limbs or seizure activity. Again, in certain glycolytic disorders, sir, like due to deficiency of phosphofructokinase, MELAS and MURF syndromes, they can develop epilepsy syndrome, sir, myoclonic epilepsy.
Okay. So thinking that mitochondrial myopathy, you asked that history. Involuntary movements, seizures. Okay.
Yes.
Right. Next symptom is cardiac symptoms. You asked chest pain, palpitations, swelling of lower limbs, breathlessness, and syncope. Why in this pure motor weakness, bilaterally upper limb symmetrical, you ask these cardiac symptoms?
Usually in hereditary myopathies, other cardiac, other organ involvement like cardiac involvement can be there, especially in
Can you
Duchenne.
name the myopathies which are involved with the cardiac involvement? Can you tell from pediatric age group till the adult age group?
Pediatric age group usually Duchenne's muscular dystrophy and Becker, sir.
Yeah, Duchenne's and Becker's will have cardiac involvement. Then in the adult,
Sir, limb girdle muscular dystrophies
limb
can cause
girdle,
cardiomyopathy. Yes,
limb girdle.
Yes, sir.
Even Emery Dreyfus can have correct cardiac involvement. Even some of the distal myopathies also can have cardiac involvement. So thinking that you ask cardiac symptoms, very important in any pure muscle disease when you are thinking you have to ask for the cardiac symptoms because there will be association with the cardiomyopathies. Yeah, correct.
No history of cramps, contractures and pain.
Yeah, you ask history of cramps. Okay, right. Where you get cramps? Cramps is a feature of whether it is a muscle disease or a nerve disease.
Usually nerve disease, sir, in motor neuron disorders.
Motor neuron disease, classically you get cramps, early morning cramps in unusual areas. And it's a feature of radiculopathy and neuropathy. Can a muscle disease cramps is a feature?
Sir, again, in some metabolic disorders like CPT2 deficiency.
Usually a muscle disease cramps is not a feature of muscle disease. Okay. The cramps is usually abrupt in onset and it is a short in duration and it is triggered by voluntary movement. Then it will produce abnormal posturing of the joint. As I told, it occurs in neurological diseases like amyotrophic lateral sclerosis. You won't get in a muscle disease the cramps. But because there's only pure motor involvement, you have to ask history of cramps.
Yes, sir.
Then you ask history of contractures.
Yes, sir.
What is contracture? Whether contracture and cramps are both same or different?
Sir, contracture, usually the muscle is unable to relax after a active contraction.
Unable to relax after a contraction is the contracture. It is because of the energy paralysis. The glycolysis will be a problem, the failure in glycolysis, and EMG will show the electrical silence in a contracture. But some muscle disease will have a contracture, very typical feature. Which are those muscle disease contracture is a feature?
Usually Emery Dreyfus, they have prominent.
And Bethlehem, they will have a contracture is a feature. Then there is a fixed contracture which refers to a muscle that cannot be passively stretched, okay, to its proper length. So contracture is you asked. Then you ask pain. Why you ask pain? Muscle pain.
Usually some toxin induced and even inflammatory myositis.
Inflammatory myopathies, polymyositis like that. So they'll have pain, the muscle disease. So thinking that you ask for the pain. Okay. And here, because you ask history of cramps, contracture, and pain, some other points also I want to mention. Asthenia, you should have asked how to distinguish a true muscle weakness from asthenia.
Asthenia, they usually have other symptoms like excessive daytime sleepiness.
Very good. They want to tend to take a nap, excessive daytime naps, sleepiness, and they avoid physical activity. And they'll have excessive stress and depression. The activities require more concentration, like reading, they avoid it. That is asthenia. So to always rule out a real motor weakness from asthenia. And all these symptoms like cramps, contracture, and one more is myotonia. They may tell there is a difficulty in relaxing the muscles.
Yes, sir.
Okay, so myotonia also you have to ask. Can you define what is myotonia?
Myotonia is usually, again, prolonged contraction will be there. And
prolonged contraction, very good. Followed by a slow relaxation. Is a myotonia. You have a percussion myotonia and action myotonia. There are two types of myotonia. You can elicit by percussion, or if the patient put into muscle into action, you may get a myotonia. Can you tell the diseases which can produce myotonia?
Sir, usually myotonic muscular dystrophy type 1, sir. And
Both type 1 and type 2 myotonia dystrophy will have the myotonia. Hyperkalemic periodic paralysis, congenital
yes,
myotonic dystrophy, paramyotonia congenita.
yes,
So all these will have the myotonia. Some patient may come with a history of myotonia symptom itself. Okay.
yes.
So cramps, contracture, pain, myotonia. Then also stiffness. Some patients may come with the stiffness. If stiffness
Yes,
is
sir.
there, what disease you would think if one patient comes with a muscle stiffness?
Stiffness, again, motor neuron disorders, sir. Like
Okay,
MS.
that is one. And also, there are some muscle disease will be associated with stiffness called stiff person syndrome
Yes,
and
sir.
also
Stiff
Isaac
person.
syndrome. They will have a muscle stiffness. So all these
Yes,
points in the history, you can elicit the symptoms. Okay. The next
yes.
point is there is no history of cognitive disturbance. Why you have cognitive disturbance?
The cognitive,
Which
usually
muscle disease will
mitochondrial
have
now.
a low IQ?
The myotonic dystrophies,
Okay,
mitochondrial
myotonic dystrophy, low IQ. Correct
yes,
then. Any
even
pediatric age group diseases?
even Duchenne's and Becker's.
Yeah, both British and Beckers will have a mental retardation. So for that point, you can ask history of any cognitive disturbances. Then you ask history of all the systemic symptoms like respiratory, cardiac, and liver failure symptoms. Why thinking what you are asking those liver, respiratory, and cardiac symptoms?
Any systemic
Hmm.
conditions which cause respiratory, cardiac, or liver failure can cause again proximal muscle weakness.
Yeah.
And
Usually they have fatigue. Fatigue is a more prominent symptom than the muscle weakness, but still you have to ask all these whether he is suffering from these diseases. That is whether he is having a proximal muscle weakness. You have to ask all these symptoms. Okay, good. Next slide. Go to the past.
coming to the past history, there is no history of diabetes mellitus, systemic hypertension, tuberculosis, or any underlying pre-existing illness. Coming to personal history, diet is mixed, bowel and bladder normal, sleep normal, no addictive habits, and no high risk behavior.
Yeah.
Coming
Continue.
to the family history, the patient's grandfather, as we can see here in the pedigree chart.
One. So in the family history, okay, you tell families, then we'll discuss families. Yeah, continue.
So here, the patient is indicated by the arrowhead, which is shown, and the patient's grandfather and siblings were affected. Coming to the second generation, here we can see that there are eight of them, out of which seven are male and one is female. And out of the eight, we can see four males have been affected, and the second one is the father of the patient. So here we can see that this inheritance is showing an autosomal dominant inheritance.
Vertical inheritance. Grandfather is
Vertical.
affected, father
Yes.
is affected, patient is affected. A vertical inheritance.
Yes.
So autosomal dominant inheritance. Why not all are affected? Because the variable expressibility and incomplete penetrance.
Okay.
Only 50% will be affected in autosomal dominant. Sometimes may not even 50% because of the variable expressibility and incomplete penetrance. But 3 generations are affected autosomal dominant. Okay. So classic family is present in this case.
Yes,
So it's
sir.
a very like mathematical logical. So there is a proximal muscle weakness, bilaterally symmetrical, slow
Yes.
onset, persistent, insidious, along with facial involvement, and there's an autosomal dominant history.
Yes, sir.
So a very logical and a simple analysis.
Yes.
So family history is there. So it's a hereditary myopathy. So it's a
Yes, sir.
hereditary myopathy, inherited myopathy disease.
Yes.
Okay. Can you tell where all family history is important in a muscle disease? Can you tell?
Sir, usually autosomal dominant, it is seen especially in fascio scapular-humeral dystrophy.
Okay,
And
fascio scapulo-humeral autosomal dominant is seen. Okay.
yes, sir, oculopharyngeal and myotonic dystrophy also.
Very
It's
good. Myotonic dystrophy also autosomal dominant. Oculopharyngeal also autosomal dominant. Very good. X-linked recessive, can you tell some of the muscle diseases? X-linked recessive.
X-linked is usually the hereditary myopathies like Duchenne's and Becker's muscular
Very good.
dystrophy.
Duchenne's and Beckers is X-linked. Even Emery-Dreifuss is X-linked.
Yes,
Can
sir.
you tell autosomal recessive inheritance muscle disease?
Autosomal recessive, usually the focal myositis can cause.
No. Focal myositis is acquired. Or they'll have a inflammation of the muscle. Limb girdle. Limb girdle has a both autosomal dominant as well as autosomal recessive inheritance. Limb girdle. And some of the inherited myopathies are also autosomal recessive. Okay.
Yes.
So the family history is very important. And here there's a classic autosomal dominant pattern of inheritance. Oh, good, excellent.
Coming to the treatment history, patient did not give any history of drug intake in the past.
Why that history is important? Drug history in this case.
So many drugs, like especially lipid or cholesterol lowering drugs.
The drugs can produce a myositis and proximal weakness. Can you name some other drugs which can produce a proximal muscle weakness?
So glucocorticoids.
Very good. Commonly used. Whenever they ask the drug history, here you tell two drugs. One is glucocorticoids. Then next is
statins, sir.
statins. Okay, the cholesterol reducing agent. Statins. These two you have to tell whenever they ask drug producing a proximal weakness. Can you tell the other drugs which can produce a proximal weakness apart from these two? These two are the commonest.
Yes, sir. Other lipid lowering agents like
another lipid lowering agents like niacin, fibric acid. Then
ezetimibe, sir.
And
ezetimibe, sir.
Ezetimibe. Okay, but not common. Then
other drugs like hydroxychloroquine, colchicine.
Chloroquine, hydroxychloroquine, there are hydrophilic drugs can produce. Correct. Then drugs of abuse like alcohol, amphetamine, heroin, cocaine, meperidine.
Yes,
then you can have the antimicrotubule drug, that is colchicine. Then zidovudine, antiretroviral drug, can produce mitochondrial myopathy, drag the red fibers. The neuromuscular, non-depolarizing neuromuscular agents can produce proximal weakness. Okay, so the drug history is very important. Right. Next, you summarize the history.
Yes.
First, after summarizing the history, you give the anatomical localization, pathology, then the diagnosis.
Coming to the summary of the history, a 42-year-old male patient who presented with bilateral proximal upper limb persistent weakness, which was insidious in onset, gradually progressive in nature, with history of associated facial muscle weakness, and along with that, a positive autosomal dominant family history. There were, however, no distal limb involvement, no history of ptosis or weakness suggestive of extraocular muscle involvement. There's no history of neck or truncal muscle weakness. There's no history of lower limb involvement, sensory disturbances, or any history of bladder or bowel disturbances. So here it was purely a bilateral proximal upper limb persistent weakness with facial muscle involvement. And also, considering the positive family history, I would like to localize the lesion here to the muscle of the motor unit. And coming to the etiological diagnosis, since there's an autosomal dominant hereditary involvement or inheritance, and there's a progressive persistent weakness suggestive of a degenerative form, here I would like to consider the probable diagnosis of hereditary myopathy, that is Fascio Scapulo-Humeral dystrophy.
Yeah, in the straightforward case, with the classic families, facial involvement, proximal, bilateral symmetrical, progressive over the years. But still, for the logical discussion and other differential diagnosis, whether you have considered or whether you can approach in a logical way the muscle disease, I want to put some of the diseases to you. Can you tell the points for and against why this is not those diseases, those diagnoses? Okay. Can it be amyotrophic lateral sclerosis, Josna, MND? What are the points against it?
Usually, nearly early morning cramps will be seen.
More important than that, you go from mode of onset, the age like that you go, and symptom wise you go late. At what age the motor neuron disease usually manifest?
Usually in third decade.
Third decade. Here in the 9th standard only you started the weakness. That is one. And here there is a family history. You will get a family history in MND.
No, sir. No family history.
Only few around, there are few variants, around in 5 to 10% they may get family history. Otherwise, it is sporadic disease, MND. Okay. So classic family history is here. That's one point against it. Then anything to suggest against MND in this case?
So coming to the complaints, usually they complain more of twitching, fasciculation, stiffness.
Stiffness. So stiffness will be there, okay, because of the human involvement. Here there is no history of stiffness to say it is corticospinal tract is involved. So this is the points against MND, that's why you cannot consider MND. Okay, now I'll tell why you can't consider inflammatory myopathies like polymyositis or dermatomyositis or immune-mediated necrotic myopathy?
Usually, again, there's no family history here.
In the inflammatory myopathy, family history won't be there. Okay, then the mode of onset, what is the progression and mode of onset there? Inflammatory myopathies. In a polymyositis or dermatomyositis, within how many duration it will manifest?
Usually, in inclusion body,
Months. It will be months. Usually 1 month, 2 months. It will manifest. It won't be like years like this degenerative disease. Okay.
Yes. Yes.
Okay. Then Puja Balaji is telling yes, rashes. Then sometimes they may come with a rash.
Yes.
Okay. Then the age of onset varies between different polymyositis, for the different inflammatory myopathy. But the family is one, and the mode of onset here it is over the years with progress. There it is usually months. Inflammatory myopathies.
Yes.
Why not it is myasthenia gravis?
Sir, here usually they have fatigable weakness, sir. Intermittent fatigable.
Intermittent. The salient point is intermittent weakness in the myasthenia gravis. But here there is a persistent weakness. And that is the point as myasthenia gravis. Okay. Can it be a GBS, Guillain-Barré syndrome? Why you can't consider GBS here?
So again, the onset is acute and
GBS is acute inflammatory demyelinating polyneuropathy. That is one difference. Any other difference in the history, you can tell it is not GBS. One is correct. Mode of onset.
Again, it is ascending, so predominantly
ascending. First lower limb and then the upper limb. It usually ascends. Yes. Good. Can you consider periodic paralysis? Why you can't consider periodic paralysis?
Periodic, again, it's usually episodic, intermittent weakness.
Intermittent weakness. It comes under intermittent weakness, muscle disease. Muscle disease. Then any other difference?
No facial weakness, sir.
There won't be any cranial involvement in periodic paralysis. Cranial, sir, rarely involved in periodic paralysis. And even it will involve both upper limb and lower limb. It won't involve only upper limb. Periodic paralysis. So you cannot consider periodic paralysis at all. Can it be a compression at cervical level producing both the upper limb weakness? Why you can't consider?
Usually it's asymmetrical involvement, sir, with the root pain.
Asymmetrical. Compression myelopathy is asymmetrical, it is symmetrical. Any other difference?
So root pain, concomitant.
Root pain is a feature of compressive myelopathy. Here there is no root pain. Okay. So these roots out and even sensory disturbance they allow compressive myelopathy because of the compression of the dorsal column. They allow a sensory disturbance. So these things we cannot consider only. It is a straightforward case, but the examiner may ask other differential diagnosis whether you know approach in a logical way the CNS case. Okay. Yes. Sir. Okay, now you approach nicely the anatomy, pathology, and this one. In the approach to muscle disease, I want to tell at the end of history a few points now. Usually, muscle disease is about the pattern of weakness they manifest. Yes. Before telling all these the varieties of the muscle disease manifesting, first I want to tell now, and even at the end I want to the muscle disease usually myopathies are usually proximal, bilaterally symmetrical, no sensory disturbance, and preserved reflexes. Okay, and no bolum bladder involvement. So mark my sentence. The myopathies will be bilaterally symmetrical, proximal, no sensory disturbance, no bolum bladder involvement, and preserved reflexes till the end. Only in the end the reflexes may be absent, but till the end the reflexes will be preserved. This in general the myopathy. But there are some other typical presentation of the muscle disease where you can diagnose the diseases. So which I will tell now, and also I will tell the approach. How will they come with a persistent weakness? How will they come with the intermittent weakness? How do you approach it? So usually the proximal muscle weakness is there, then you will consider these hereditary myopathies what we are discussing, all these limb-girdle, Fascio Scapulo-Humeral, Duchenne's, Becker's muscular dystrophy, or inflammatory myopathies like polymyositis, dermatomyositis, or even neuromuscular junction disorders like myasthenia gravis, or a toxin-induced or endocrinological induced congenital myopathies, and hereditary myopathies, and metabolic diseases like glycogen disorders or fatty acid disorders. All these will come with a bilateral proximal muscle weakness. This is one category of the muscle diseases. Then some muscle disease may come with a distal muscle weakness. Rare, again, I am telling, these are all the rare presentation. There are some hereditary distal myopathies, distal myopathies, like myofibrillar myopathy, congenital myopathy, metabolic myopathy, and even neuromuscular junction. Sometimes, very rarely, they may come with a distal muscle weakness. Very rarely. Then the third variety is proximal arm in the lower limb, the distal leg involvement. Okay, proximal arm in the lower limb, distal leg involvement. In this category, you get Fascio Scapulo-Humeral, then myofibrillar myopathy, Emery-Dreifuss muscular dystrophy, and Bethlem myopathies in this, where upper limb proximal and lower limb distal leg involvement. Then one variety, inclusion body myositis, there will be involvement of the proximal leg, the thigh muscles, but in the hand, in the upper limb, there will be a hand involvement. So upper limb distal, lower limb proximal is inclusion body myositis. Then there can be axial muscle involvement in some of the myopathies. Only axial muscle involvement will be there. For example, cervicobrachial myositis. Some variants of inclusion body myositis, myotonic dystrophy type 2 can have an axial muscle involvement. Then hyperparathyroidism, osteomalacia, vitamin D deficiency can have an axial muscle involvement. Then eye involvement, you ask in the history whether ptosis is there or not in this case. So usually in the muscle disease, whenever there is eye involvement, we will classify into two things. Ptosis without ophthalmoparesis, ptosis with ophthalmoparesis. Only ptosis will be there, but eye movements will be normal. That is ptosis without ophthalmoparesis. You get that in myotonic dystrophy. Only ptosis will be there, but no ophthalmoparesis. And also in some of the congenital myopathies. Whereas ptosis with ophthalmoparesis, along with ptosis, the eye movements will be abnormal. You get in oculopharyngeal muscular dystrophy and mitochondrial myopathies. Ptosis with ophthalmoparesis. Then episodic weakness, we may come with episodic weakness. If there is episodic weakness, you will consider the periodic paralysis, myasthenia gravis, which is a neuromuscular junction disorder. It is not a muscle disease, it is a neuromuscular junction disorder. But still, you will be considered in the differential diagnosis of muscle disease because it is only pure motor involvement, not a sensory involvement. So episodic weakness, neuromuscular junction disorder, periodic paralysis, and some of the metabolic problem, glycolytic problem, fatty acid problems can have intermittent episodic weakness. Then the next category is the muscles with the stiffness. That is muscles with the myotonia. You get a myotonia dystrophy, both type 1 and type 2. Hyperkalemic periodic paralysis, myotonia congenita, paramyotonia congenita. You get a muscle stiffness. And also, as I told, some rare stiffman syndrome, Isaac syndrome, Schwarzman-Jankel syndrome, you get a muscle stiffness. So all these varieties, it can present a muscle disease. But a postgraduate student should not get confused. Always for him, muscle disease is bilaterally symmetrical, proximal, no sensory, preserved reflexes till the end, no bone and bladder. But there are rare diseases which can present with these typical manifestations. So there are myopathies by the pattern of presentation, and then approach to a muscle disease if there is an intermittent weakness or if there is a persistent weakness. Can you tell if there is intermittent weakness, how do you approach, Josna? If you know, you can tell intermittent weakness, if it is there, how do you approach?
Sir, initially we have to check the urine for myoglobin excretion, sir. If that is positive, then we go ahead with the forearm exercise. On doing the forearm exercise, we have to look for the level of the lactic acid, sir.
Good.
If the lactic acid level is not rising with forearm exercise, then you have to think of a glycolytic defect.
Very good.
And we do a gene testing. And if even with that, the diagnosis is not confirmed, then we do a biopsy. And if there's a normal
lactic acid is increased, you told if it is decreased, you will think of a glycolytic. If it is increased property, what you will think?
Then instead of carbohydrates, we think of the fatty acid metabolism.
Yeah, fatty acid and carnitine palmitin deficiency. You think that carnitine palmitin transferase deficiency, you will think. Good, correct. This is if there is a myoglobinuria is positive. If no myoglobinuria, how do you approach?
Sir, again, we have to see whether along with the muscle along with the myoglobinuria, there's other muscle involvement. For example, extraocular muscle involvement, ptosis, bulbar or limb muscle involvement.
So if no myoglobinuria, you will see whether a ptosis or a bulbar or limb muscle is involved. You will see. Suppose if that is involved, how do you approach next?
Then to rule out myasthenia gravis, sir, we check for the acetylcholinesterase receptor in antibodies and MuSK antibodies.
Very good. If that is positive,
then it is myasthenia gravis, sir.
Suppose if that is negative,
then we go for other investigations, so like repetitive nerve stimulation.
2 to 3 hertz repetitive nerve stimulation test, and you will do single fiber jitter EMG. You will do. Suppose if that is positive, the repeated nerve stimulation decremental response, and if there is a jitter on the EMG, if that is positive, what we will consider?
Usually we consider Lambert
Lambert syndrome. Then you will do for a voltage gated calcium channel antibodies and for a chest X-ray for a carcinoma of lung. Suppose if single fiber jitter is negative and repeated 2 to 3 hertz repeated nerve stimulation test is negative, then what you will consider?
Some cases of myasthenia gravis can be seronegative, so which don't show up with the antibodies.
And congenital myasthenia gravis. Or it could be a psychosomatic, as I told, asthenia. It could be just a neuroasthenia, what I told. It could be any of those things. Very good. So if myoglobinuria is not there, you will consider these things. And also, if ECG is showing abnormality, how do you approach? Suppose if the examination is normal in between the attacks, proximal is more involved than a distal, and ECG showing abnormality along with dysmorphic features like hypertelorism, broad forehead, phenodactyly.
Yes, sir. Those features usually indicate Anderson-Tawil syndrome.
Anderson-Tawil syndrome. Suppose if ECG is normal and if there is a myotonia in examination.
Yes, sir. If it is present, then you have to check for the potassium level, sir. If it is normal or elevated, then hyperkalemic periodic paralysis. And
if it is normal, hypokalemic periodic paralysis.
Yes.
If it is reduced, if potassium is reduced, it is hypokalemic periodic paralysis. If it is increased, it will be hyperkalemic periodic paralysis. If it is normal, you will think of a paramyotonia congenital. Because in all these things, this hyperkalemic and paramyotonia congenital, there can be a myotonia. If myotonia is not there, if potassium is less, you will consider hypokalemic periodic paralysis. So this is an intermittent weakness. So mainly neuromuscular junction disorder, periodic paralysis, and then glycolytic and fatty acid problems. We put the intermittent weakness, but our patient is having a persistent weakness.
Yes.
If one patient has intermittent weakness, you will consider like this. Suppose if there is a persistent weakness, Harrison says it can present in a 7 variants. Can you tell what are the 7 variants it can present?
The most common is proximal more than distal.
Yeah, usually, see, muscle disease means for a postgraduate level, it should be proximal, typical bilateral symmetrical. Can you tell which are the diseases which will present like that? Proximal muscle weakness.
Most of the muscular dystrophies.
Correct.
Then even mitochondrial, sir. Mitochondrial dystrophies.
Even toxins, endocrine. Then all inflammatory myopathies like dermatomyositis, neuromuscular junction disorders, they all present in the proximal.
Yes, sir.
Okay. Next, what are the other 6 varieties? Can you tell?
Then, along with muscle weakness, we have to look for ptosis and extraocular muscle involvement, sir. As an
extraocular muscle involvement is there?
Oculopharyngeal muscular dystrophies and even mitochondrial myopathies.
Myopathies, they will have a ptosis with extraocular muscle involvement. Okay. Suppose if like our case, facial scapular involvement is there, what do we consider?
And it is FSHD, sir.
Fascio Scapulo-Humeral dystrophy we will consider involvement of face scapula. Suppose if there is involvement of the thigh muscles in the lower limb, upper limb hand muscles, what do we consider?
The involvement of quadriceps and distal hand muscles, so usually myotonic muscular dystrophy can cause.
No. This is the lower limb proximal, upper limb distal is inclusion body myositis. In myotonic dystrophy, there will be involvement of the facial also. Facial muscles will be involved. Along with the quadriceps, as you told, is correct. Upper limb distal can be involved. Okay. But facial muscle should be involved. And there should be myotonia to say it is myotonic dystrophy. Okay.
Yes.
Only proximal muscle involvement, upper limb distal hand, without myotonia, without facial involvement, it is inclusion body myositis.
Yes.
Then the other 2 varieties are distal myopathies. As I told, there are some myopathies which are not only distal muscles, like myofibrillar myopathy, which are also only the distal muscles. And the others is dropped head syndromes. They come with a dropped head syndromes. These are amyotrophic lateral sclerosis, polymyositis, myasthenia gravis. They are a dropped head syndrome. And even hyperparathyroidism and some of the axial myopathies, which I mentioned before, can have a dropped head syndrome. So these are the 7 varieties how a muscle disease will present. So our patient, he represents here in these 7 varieties a facial involvement, upper limb proximal involvement is fascio scapulo-humeral dystrophy. With the positive family history is hereditary myopathy.
Yes, sir.
So both the flow diagrams Harrison has given. All the students, should I request them to go through both the flow diagrams? Very important, and logically he has given both the flow diagrams. And here only, and in all these 7 varieties when they present, you do some basic investigations. Actually, first you do creatine kinase, which indicates a myopathy. If it is elevated, suggest a myopathy. Then you will do EMG. This will rule out whether it is amyotrophic lateral sclerosis or a muscle disease if you do EMG. Then you will do repeated nerve stimulation test, which another closed DT neuromuscular junction disorder. It will say whether it is myasthenia gravis or not, repeated nerve stimulation study. And then you have a DNA testing for all these hereditary, which we are discussing, hereditary myopathies. At last, you can go for a muscle biopsy, which will give clue to some other muscle disorders. They are some basic investigation. Again, I'll discuss when I come to investigation in detail about the investigation. At the end of history, this much approach should be enough. Okay. Yeah. Go ahead with your next findings.
On general physical examination, a 42-year-old male, conscious, coherent, cooperative, and oriented to time, place, and person. Coming to the vital, blood pressure 130 by 80 millimeter mercury, measured in the right arm in the supine position. Pulse rate 78 beats per minute, regular, normal volume and character. No radial or radiofemoral delay. There was no arterial vessel wall thickening. All peripheral pulses were felt. Coming to the temperature, 98.1 degree Fahrenheit, respiratory rate 18 cycles per minute, abdominothoracic type, and the saturation was 98% at room air.
Yes, continue.
Coming to head-to-toe examination, there was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. There was no cataract, ptosis.
Why you ask cataract and ptosis? Why you ask cataract and ptosis?
There are usually myotonic dystrophy presents with the posterior subcapsular cataracts. And ptosis, again, so for progressive external ophthalmoplegia or oculopharyngeal muscular dystrophies.
Myotonic dystrophy also.
Yes, sir. Yes.
Okay.
There was no baldness, no broad forehead, micrognathia, hatchet faces, in the sense no temporalis or masseter muscle wasting. There is no hypertelorism.
Why you
no
ask all these? Why you ask all these things?
So in Anderson-Tawil syndrome, usually these features are predominantly seen, sir.
Hatchet faces where you see?
Hatchet faces we see in myotonic dystrophy, sir.
Myotonic dystrophy. Yeah, the baldness also we see in myotonic dystrophy. The other features, broad forehead, micrognathia, and hypertelorism, clinodactyly, you see in Anderson-Tawil syndrome. Okay.
Winging of scapula was present.
Okay.
No contractures, no skin changes of any inflammatory myopathy.
Good, good. Next slide.
There were no signs of hypothyroidism, hyperthyroidism, or any Cushingoid-like features.
Because all this can produce proximal weakness, you look for these signs.
There's no features of acromegaly, no short stature, no calf muscle hypertrophy.
Why you look for calf muscle hypertrophy? Where you get calf muscle hypertrophy is a feature of which muscle disease?
Usually Duchenne's muscular dystrophy, limb girdle, even infiltrations.
Correct. Duchenne's and Becker's, they are calf muscle hypertrophy. Clinodactyly, I don't know the criteria. Biology asks what is the criteria for clinodactyly. Clinodactyly means the bending of the fingers. Okay. Yes. That is the clinodactyly. Biology has asked that question. I don't know the criteria. Okay. Next. No telangiectasia. Why you ask telangiectasia? Why you do telangiectasia?
Sir, in fascio scapulo-humeral dystrophy, even vasculitic conditions, systemic causes also can lead to.
Coats disease, the fascio scapulo-humeral, the disease which you are thinking, they can have exudate, retinal detachment, and telangiectasia.
Yes, sir. Yes, sir.
And gonadal why you look for gonadal atrophy?
So the gonadal atrophy.
Myotonic dystrophy. Gonadal is a feature of myotonic dystrophy. Gonadal atrophy.
Yes.
In the spine, you look for kyphosis and this one lordosis. Lordosis is mainly gait. You won't see in inspection top to bottom.
Yes.
Lordotic gait. You get proximal weakness. Lordosis. Kyphoscoliosis. Anderson-Tawil can have kyphoscoliosis.
Yes.
Thyroid you examined again for proximal weakness because of the endocrinological etiology. Next.
Yes.
Oh.
Coming to systemic examination, nervous system examination, higher mental functions. Patient was conscious, right-handed, attention orientation was normal. The mini-mental score examination score was 26 by 30, which was normal. Speech and language, there was no dysarthria, aphasia. Coming to the memory, all the components, immediate, recent, and past was intact. Calculation construction was normal. There was normal abstract thinking. Insight and judgment was normal. No history suggestive of delusions or hallucinations.
So high mental function predominantly normal. Okay.
Coming to the cranial nerve examination, first nerve, olfactory nerve was normal. Coming to the optic nerve, second nerve, visual acuity, normal. The color vision was normal. The field of vision was normal. Coming to the third, fourth, and sixth nerve, that is the oculomotor, trochlear, and abducent nerves. All the extraocular movement was normal. There was no nystagmus. Gaze was normal. The saccades and pursuits was normal. There was no ptosis, double vision, or any lid retraction. Bilateral pupillary reflexes was normal.
Okay.
Coming to the fifth nerve, that is the trigeminal nerve, the motor component. All the muscles of mastication, that is the pterygoids, masseter, were normal. Sensory part, all the three divisions was normal. The corneal, conjunctival, superficial reflexes, jaw jerk was normal. Coming to the facial nerve examination, the motor component, there was difficulty in closing bilateral eyes. There was difficulty in whistling. There was abnormal flattened transverse smile present. And there was difficulty in the same thing, the bilateral complete eye closure. There was flattening of bilateral nasolabial folds. However, wrinkling was preserved.
So there's a bilateral facial nerve affection.
Yes.
Muscles of the face here. Here the problem is in the muscles, not in the nerve, facial nerve. The problem is the muscles.
Yes.
Bilaterally, both the parts of the face, the muscles are affected. Okay. Can you tell some of the cause of bilateral facial nerve palsy?
Usually myasthenia gravis.
Okay.
Even facial, any muscle disorders, sir. The facial scapulo-humeral dystrophies.
Okay. One is the neuromuscular junction you told, another is the muscle disease you told. What are the other cause of bilateral facial nerve palsy? Go to the nerve, facial nerve involvement, bilateral facial. The commonest metabolic disease. Day to day you practice, na? Which is the commonest metabolic disease where can have bilateral facial nerve palsy?
So usually hypokalemia and diabetes. Yes.
Diabetes, Guillain-Barré syndrome.
Yes, sir.
So they can have bilateral facial nerve palsy. Lyme's disease, sarcoidosis. All can have bilateral facial nerve palsy, leprosy.
Yes.
Okay. Okay, continue.
The sensory component, that is the anterior 2/3 of the tongue, was normal. Coming to the eighth nerve, that is the auditory nerve. The Rene's test, bilaterally, both the ears, the air conduction was more than the bone conduction.
That's normal. Eighth nerve is normal. Can you get eighth nerve deafness in the disease which you are thinking?
So the hearing loss can be seen in some mitochondrial.
No, here only the Fascio Scapulo-Humeral dystrophy. You may get some patients hearing loss.
Yes.
Okay. Right.
Yes, sir.
Next one.
And Weber's test, it was lateralized equally to both the sides. Coming to the ninth nerve, glossopharyngeal and vagus nerve components were normal. Gag reflex was intact. Accessory nerve, the flexion of neck was normal. Side-to-side movement was normal. Shrugging of shoulders was normal. The last nerve, that is the 12th nerve, hypoglossal nerve, was normal.
Okay. So cranial bilaterally, facial nerve was affected. Sorry, facial muscles are affected bilaterally. Okay. So that is a finding what you got. Okay.
Coming to the motor system examination, the nutrition, that is a muscle bulk. Here, the right upper limb, arm was 25 centimeter, left arm was 25 centimeter, whereas the forearm, it is 29 centimeter bilaterally. Here we can see that the arm circumference is reduced compared to the forearm circumference.
The forearm circumference is bigger than forearms are bigger than the arms because of the wasting. Okay.
Coming to the lower limb bulk, the thigh muscles, Bilateral, it is 48 centimeters, and the lower limb, that is the leg, it is 37 centimeters.
Yes, next slide.
Coming to the tone, bilateral upper limb and bilateral lower limb tone was normal. Next, coming to the power, upper limb power over the shoulder girdle, the movements abduction, adduction. Abduction right side, it is 4/5. Winging of scapula was seen on performing the abduction movement, and on the left side, it is 4/5.
Winging of scapula is seen when they push against a wall. Okay.
Yes.
Winging of scapula is seen when they push against a wall, and that time set as anterior weakness. We put the medial part of the scapula become more prominent. Actually, the patient had a winging of scapula. That video couldn't, that photo couldn't be put here. Okay, winging of scapula was there, and it's seen when pushed against a wall at that time.
Yes, sir. Yes.
You are told abduction, adduction, flexion, extension, all 4/5 in the absence of the proximal muscle involvement. Can you tell the muscle to help in abduction?
Abduction is usually the deltoid muscle, sir.
Deltoid is the mid part. Initial part is by
supraspinatus, sir.
Later part is by the later part of
So abduction is initiated by supraspinatus.
correct.
Then it is deltoid, sir.
The later part by
Later part, it's usually by the
trapezius. Later part of abduction is by trapezius. Abduction. Adduction, which of the muscles helps in adduction?
the adduction, it's usually the pectoralis major and the latissimus dorsi.
So pectoralis major and latissimus dorsi is the shoulder adduction. Shoulder flexion is done by
The flexion, it's by deltoid muscle again.
Anterior fibers of deltoid. Anterior fibers of deltoid.
Yes, sir.
And pectoralis major.
Yes.
Flexion. Extension is by?
Extension, it's usually by the triceps, sir.
No.
Shoulder, it is the deltoid, latissimus dorsi, and the subscapularis, sir.
Posterior fibers of deltoid is extension.
Yes.
And latissimus dorsi also extension. Okay.
Yes,
you are able to hear?
Yes, sir. Yes, sir.
So posterior fibers of deltoid and latissimus dorsi is shoulder extension. Okay.
Yes, sir.
So all shoulder flexion, extension, adduction, abduction is 4/5.
Yes, sir.
Okay. All the muscle examination, I'll recommend all the postgraduates to see two books. One is the Becker staff, simply given, nicely given, and the Dijon also. So both you can go through the muscle examination. Okay. In this case, students, because here there is no sensory involvement, there is no cerebellum involvement. They'll predominantly ask how to look for the muscle action and the muscles which are involved in those action, and the nerve supply also they may ask. What is the nerve supply of deltoid, Josna?
Deltoid is circumflex nerve, sir.
Axillary nerve branch. Axillary nerve, deltoid. Circumflex. Axillary nerve. The nerve supply to latissimus dorsi?
It is nerve to latissimus dorsi, sir.
Simple to tell. Dorsal, thoracodorsal. Thoracodorsal is the nerve supply to latissimus dorsi, also called as nerve to latissimus dorsi. Okay. What is the nerve supply to serratus anterior?
Sir, C5, C6, 7.
No, not the
serratus, nerve to serratus anterior, sir.
Okay, long thoracic nerve it is called. Long thoracic nerve. What is the nerve supply to supraspinatus, infraspinatus?
Sir, suprascapular nerve.
Suprascapular nerve. Supraspinatus, infraspinatus. What is the nerve supply to pectoralis major?
Sir, lateral and medial pectoral nerves.
Lateral and?
Medial pectoral nerves, sir.
Lateral medial anterior thoracic nerve. Okay, lateral medial anterior thoracic nerve. In this case, you should know, because no other system of the no other part of CNS is involved, only muscle examination, and they'll ask the supply muscle action. You should know how to examine the muscles. Okay, should know it. Go with then you are written external rotation. Which muscle helps in external rotation? Infraspinatus. For external rotation, infraspinatus helps.
Okay.
Okay. External rotation, how to examine? Even De Jong has given, Hutchison has given. You can see the diagram.
Yes.
Okay.
Yes.
The arm will be held beside the body, and the forearm will be rotated outside for external rotation. Okay.
Okay.
Yeah.
Coming to the individual muscle examination, the pectoralis major muscle, bilaterally it could not be assessed as patient could not lift the arm forwards. And coming to the deltoid muscle, it is normal. Power is 5/5 bilaterally. Coming to the latissimus dorsi muscle, again bilaterally it could not be assessed as patient could not abduct the arm. And coming to the rhomboid major muscle, it is bilaterally reduced. The MRC grading is 4/5. And coming to the serratus anterior, when the patient attempted to push arms forward against the wall, there was a prominence of the scapula. Winging was present.
So almost all the shoulder girdles are having 4/5, the muscle power in this case. Can you grade the power? How do you grade the muscle power?
Grade 0, it is total paralysis, contraction of the muscle. Grade 1, it is only flickering or flickering movements or fasciculations.
No. Flickering movements. No, don't use fasciculation. Flickering movements.
Yes.
Grade 2.
Grade 2, it is active movement, but the gravity is eliminated.
Good. Grade 3.
Grade 3 is there is active movement against gravity, sir. But when you offer resistance, they cannot.
Grade 4.
Grade 4 is they move actively against gravity as well as resistance.
4 plus, 4 minus, 4 minus, 4 plus. Mild, moderates, severe resistance. Grade 5 is
normal.
Okay, a basic question you should know about this. Yeah, go ahead with the elbow joint.
Coming to the movements around the elbow joint, the flexion and extension both was the power was reduced. It was 4/5 bilaterally. However, the pronation and supination was normal. Coming to the wrist, finger.
Elbow flexion is done by which muscles?
It's the biceps, sir.
And brachialis. What is the nerve supply to biceps and brachialis?
C5, C6. Sir.
Not the root value, the nerve name. Musculocutaneous nerve for biceps and brachialis. Yes. Extension is done by?
Triceps, sir.
Nerve supply?
Radial nerve supply.
Go ahead.
Coming to the movements around the wrist joint, fingers, thumb, all the components, that is flexion, extension, adduction, abduction, was 5/5 bilaterally, and the hand grip was normal. Coming to the lower limb muscles around the hip joint, adduction, abduction, flexion, extension, all was normal. Coming to the movements around the knee joint, both flexion extension was 5/5 bilaterally.
Left side you have written 4/5, no? Hip adduction, abduction, flexion, extension. Yes, lower limb hip, left side there is a 4/5 abduction, adduction, flexion, extension. Yes, symptom wise, he didn't tell there is a proximal muscle weakness. He could stand up from sitting position. He never had a weakness. But on examination, there is a weakness. Is it described the hip muscles, the pelvic muscles will be involved in the disease which you are thinking, this fascio scapulo-humeral, whether it is described? If it is described, how many % will have that? Usually it is rarely involved, sir. Around 20%. Around 20%. Yes. 20% they can have a hip girdle, the hip pelvic involvement is given. Okay. Coming to the movements around the knee joint, both flexion extension was bilaterally normal, 5/5. Coming to the movements around the ankle joint, plantar flexion, dorsiflexion, foot inversion, eversion was normal, 5/5. And coming to the toes, that is flexion extension bilaterally toes, 5/5. Yes. Yeah. So here it is explain this. Here it is a picture showing by the arrowhead marks, the red arrowhead marks. So here we can see that there is bilaterally upper limb proximal muscle wasting. We can see the forearms are
bigger than the arm circumference. So this
the
shows
arm
that
is smaller than the forearms. Yeah.
yes, sir.
Students, all the other the findings, being of scapula, facial involvement, everything is there. It has been recorded in the prep clinic app. It is there. You can download and you can see the patient finding in the prep clinic app. Students, everything is there. Continue just.
Coming to the coordination, bilateral upper limb and lower limb was normal. Coming to the reflexes, bilaterally superficial reflexes, that is the corneal, conjunctival, abdominal, cremasteric, anal, and plantar, all were elicitable, and bilateral plantars was a normal flexor response. Coming to the deep tendon reflexes.
Why does the plantar reflex is important here?
To rule out upper motor neuron.
Yeah, because one of the diseases what we thought was the amyotrophic lateral sclerosis. Corticospinal tract will be involved. So to rule out that, plantar reflex is important here. So it's a bilateral flexor. Okay. Go back to the previous slide. What has happened to the reflexes?
So all the deep tendon reflexes, that is the upper limb, triceps, biceps, supinator, and lower limb, knee, ankle, all are preserved, and it is normal, sir. 2+.
So it's normal. Okay.
Normal.
Right.
Normal.
So here at the end of muscle examination, Harrison has given some of the typical pattern of the weakness will suggest some of the muscle diseases. For example, if Bowers sign is there,
yes,
especially in Duchenne's muscular dystrophy and Becker's muscular dystrophy, they'll climb on their own body. That indicates the hip muscle weakness, the thigh muscle weakness. Suppose if there's a lumbar lordosis which is exaggerated by toe walking, that indicates proximal muscle weakness. Then the gait, if there's a waggling gait, that again indicates a proximal muscle weakness. And if they walk with the hyperextension of the knee, then that is because of quadriceps muscle weakness. Then, as you told in this case, if they cannot close the eyes tightly, that indicates the upper facial muscles involvement. If they cannot pucker with their lips, that indicates the lower facial muscle involvement.
yes, sir.
And one more, you should have examined is whether it could flex the neck with the resistance and whether it could extend the neck in a prone position. That you should have examined. Because inability to flex the neck in a supine position is a neck flexor muscle weakness. Inability to extend the neck in a prone position, neck extensor muscle weakness. And like in this case, inability to lift the hand above the head with a proximal upper limb muscle weakness will be there.
Yes.
Then inability to stand up from a sitting position, again a proximal muscle weakness, waggling gait, then hyperextension of the knee, that is because of quadriceps muscle weakness. Then gait, if there is a high steppage gait, that indicates anterior tibial muscle involvement weakness. If their inability to walk with the heel touching the ground, that is because of the fixed contracture of the gastrocnemius muscles. So some of the weaknesses will give a clue which muscles are involved, and some of these gait and other weaknesses will give clue which muscles are involved in muscle examination. This Harrison has given on table, okay, the functional impairment and the muscle weakness. You can all of you can go through that. It's a nice table. So which muscle is involved because of which weakness. So here the reflexes are normal, plantar is flexor. Next slide.
Coming to the primitive reflexes, they were absent. Involuntary movements were absent. Coming to the sensory system examination, the exteroceptive sensations like pain, fine touch, temperature to both hot and cold was normal. Coming to the posterior column or dorsal column sensations, that is position sense, joint position, vibration sense was normal. Romberg sign was negative. And all cortical sensations, that is graphesthesia, 2-point discrimination, tactile localization, and stereognosis was intact.
So history-wise also symptom is he never had any sensory symptoms. On examination also sensory system is normal.
Yes.
He never had any ataxia also history-wise, so cerebral system is also normal.
Yes.
Only motor weakness he had, and on examination also you got only those findings.
Yes, sir.
Okay, next slide.
Coming to the posture, stance, gait, and spine examination, all was normal.
Left side you told 4/5 flexion, extension, adduction, abduction, but in spite of that, gait is
normal.
Normal. It is not affected this gait. Okay.
Yes. There were no signs of meningeal irritation. Autonomic nervous system examination was normal. There was no postural drop of blood pressure, no supine or standing hypotension.
Yeah, good. Okay.
Coming to the other system involvement, cardiovascular system examination, S1, S2 was heard. There was no murmurs. Respiratory system examination, bilateral normal vesicular breath sounds heard. There was no adventitious sounds. Per abdomen examination, soft, non-tender, no palpable organomegaly, no free fluid in the abdomen, bowel sounds was heard.
Yeah, that's nice. So especially cardiovascular, you have to see in these muscle diseases because of the associated cardiomyopathy. And even the pulse rate, where you get a heart block, which muscle disease?
So usually the hereditary myopathy is like Duchenne, sir.
Here cardiomyopathy will be there. Especially heart blocks is a feature of myotonia dystrophy. Complete heart block they can develop. First degree complete heart blocks they can develop.
Okay.
So at the end of history, you thought some of the differential diagnosis. Okay. Now, can you rule out all those differential diagnoses? Why you can't consider them? Why it is a fascio scapulo-humeral only? At the end of examination, MND, you got any points in favor of MND? You thought one of the DD as MND.
Yes, sir. So there was no feature suggestive of upper motor neuron involvement.
Like?
The reflexes was normal.
Very good, very good. Reflexes are not exaggerated. Good. Then
the tone was normal, sir. Tone was normal.
Tone, there is no hypertonia. Very good.
Yes, no hypertonia, and bilateral planters were flexor.
Plantar is flexor. These okay. On examination also, you are not able to think MND. Very good.
Yes.
And why it is not Guillain-Barré syndrome?
Sir, usually there is areflexia.
Very good. Areflexia is a feature of Guillain-Barré, but here reflex are preserved. Nice. That's nice. The myasthenia gravis, history only you ruled out the myasthenia gravis because of the intermittent weakness.
Yes, sir. Yes, sir.
Compressive myelopathy, on examination, any findings against compressive myelopathy?
Sir, again, usually sensory system involvement will be there, sir.
Correct, sensory system involvement. And even tone, there will be.
Yes, sir. Hypertonia.
Hypertonia. Plantar also will be.
Yes.
So examination also same thing. You ruled out all these things. Okay. Yes. Now interpret your findings and give your diagnosis.
On examination, the neurological deficits which was elicited was bilateral symmetrical shoulder girdle muscle involvement, proximal upper limb muscle weakness with prominent scapular winging. Along with this, we have also seen that the left lower limb, there was proximal muscle weakness. That was 4/5. Apart from the muscle weakness, the upper limb and lower limb, there's also bilateral low motor neuron facial muscle weakness, otherwise known as facial diplegia. Coming to the anatomical localization, here I would like to localize the lesion to the muscle of the motor unit. And coming to the etiology, here we can see that the onset was in childhood or early adolescent, we can tell. And there was a typical positive family history of autosomal dominant inheritance. And the weakness was persistent, it was progressive over the years, suggesting a degenerative process. So here, because of the typical proximal muscle involvement, and of course, as Sir said, in 20%, there could be even a lower limb proximal muscle involvement. And along with this, there was bilateral facial muscle weakness, suggesting yes, sir. So the diagnosis, I would like to infer it as fascio scapulo-humeral dystrophy.
At the end of history also, you thought that one. This is such is a strong importance of history in CNS. History only will give clue to the, you can diagnose the disease. Your examination, you only add, it is substantiate your diagnosis. Okay.
Yes, sir.
And because such a classic clinical case diagnosis, they have not even done any investigation to diagnose this.
Yes,
we have done the genetic studies to confirm the fascio scapulo-humeral dystrophy. Okay.
Yes,
so usually here there was a creatine kinase was mildly elevated in this case.
Yes.
Fascio scapulo-humeral dystrophy. And what investigation usually you do in any muscle disease?
So, usually we do for PK levels, the creatine.
First is creatine kinase level you will do, correct. Then because endocrinological disease also can put a proximal weakness like this, you can do the PSH analysis, vitamin D levels and parathormone levels. Then inflammatory myopathies to rule out, you can do autoantibodies. In the inflammatory myopathies, some of the autoantibodies will be present. So to rule out that, you can do autoantibodies. Then forearm exercise test, as you told, if there is an intermittent weakness, you will consider a forearm exercise test in intermittent weakness.
Yes, sir.
Then muscle biopsy is last in inherited myopathies because nowadays genetic analysis is available, cheap and everywhere available. They go for genetic studies.
Yes, sir.
Okay, only muscle biopsy you do only for acquired myopathies, not for inherited myopathies like this.
Yes, sir.
And you can do electrodiagnostics tests like EMG, nerve conduction study, repeated nerve stimulation study. Repeated nerve stimulation study to distinguish from myasthenia gravis. EMG to distinguish from amyotrophic lateral sclerosis. So these are the investigation you do. A few points about the other investigations. In EMG specifically, you look for a irritability on a needle insertion. That irritability on a needle insertion you get in the inflammatory myopathies like inflammatory, the polymyositis, dermatomyositis, then muscle dystrophies, toxic induced myopathies, and myotomic dystrophies. You get irritability and needle insertion. Whereas loss of this irritability you get in the endocrinological cause of myopathies, then metabolic cause of myopathies, and tissues atrophies. Then the EMG, one point is in steroid-induced myopathy, EMG will not show any change because in a corticosteroid, the affected muscle will be type 2 fiber atrophy. That is why you won't get any EMG changes in corticosteroid-induced myopathy.
Yes.
As I told, genetic test is a gold standard for hereditary myopathy. It means that should have been done to confirm, but because so classically, clinically, they have not done any genetic studies. Then forearm exercise test, if the patient has an intermittent weakness, you will do that. The lactic acid level will increase typically 3 to 4 times in a forearm exercise test. You will also measure the amino acid level. Amino acid level acts as a control. For example, if there is a lack of effort in a forearm exercise test, then both amino acid as well as lactic acid won't rise if there is lack of effort from the patient. Whereas in a glycolytic disorder, lactic acid won't rise, but amino acid will rise because it acts as a control that will rise. So that way it will be useful to diagnose intermittent weakness forearm exercise test. Then the muscle biopsy, as I told, it is used in acquired myopathies, not in a congenital myopathies. You have to take only the muscles which are clinically affected, like our patient, 4/5. 4/5 is the ideal muscle to do the biopsy. Those are superficial muscles, that only you have to biopsy. Not a very totally atrophied muscles, you should not take it for a biopsy. Okay. Yes. Then can you want to tell a few points about Fascio Scapulo-Humeral dystrophy?
Yes, sir. Sir, it is a typical autosomal dominant disorder. And here there is usually proximal muscle involvement predominantly than the distal muscles.
Upper limb, okay.
Yes, sir, upper limb. And in 20%, even the lower limb also can be affected.
Is cardia involved? Is cardiomyopathy is a feature of
no, sir.
Polymer?
No, sir. The heart is
cardia is not involved. In our patient also, cardia is not involved. Even his father, grandfather, in nobody, heart was not involved. Cardiac involvement is not a feature of Fascio Scapulo-Humeral dystrophy. And what the books are given is whether phase involved early or the limb muscles are involved early.
So usually the facial muscle weakness is the initial manifestation.
So our patient is little atypical. He has given facial muscle involvement is early, then the limb muscle involvement. But our patient, first involvement is in the limb and then the facial muscle involvement. Okay. Yes. Then about the elbow flexion, extension, and deltoid, what he has given the weakness?
So usually the biceps and triceps are severely affected, and that's why
compared
there's
to deltoid. Compared to deltoid, flexion and extension is severely affected. Even our patient was also flexion and extension was severely affected compared to the deltoid. Even our patient. Right. Then can they have foot drop?
So?
Foot drop.
The foot drop can also be there in the lower limb, especially
foot drop also can be there. Okay. Can they have the nerve deafness as you told in the cranial examination? Some patients can have a nerve deafness in the
yes, sir.
Eye involvement.
Especially in Coats disease, there could be retinal detachment or exudation.
And telangiectasia.
Yes,
Okay.
yes.
Right. So coming to the laboratory investigations, creatine kinase will be only mildly elevated. In him only they have done that. The creatine kinase they have done slightly it was elevated. The creatine kinase. And EMG will be a non-specific feature in Fascio Scapulo-Humeral dystrophy. And as you all know, it's a hereditary myopathy. There's no treatment for this Fascio Scapulo-Humeral dystrophy.
Yes, sir.
There are other inherited myopathies given in Harrison. If in the theory part, all of you can go back and read the other inherited myopathies. I have one more case, myotonia dystrophy. I'll discuss that case, myotonia dystrophy, probably after some or another 2 or 3 weeks down the line. Okay. So at that time, we can discuss about the other inherited myopathies. What are the other inherited myopathies? Some theoretical part about that. So a nicely presented case by Josna. So next after 2 or 3 weeks, we present myotonia dystrophy. Then all these, what are the findings? Everything is there. A video has been made and it has been uploaded in Prep Clinic app. So you can download the app and we can see the video. Prep Clinic app, the same case. Next, we'll discuss some of the cardiology cases like ASD, phthalates, and myotonia dystrophy within the coming weeks. Any doubts?
One question they've asked is, what is the management for this patient? What should we do for him?
Management physiotherapy. He is doing exercise. He tells every day, half an hour to 1 hour, he will do exercise. He's telling. So only physiotherapy is the only treatment. There is no other specific treatment, Balaji, for these inherited myopathies. These congenital myopathies, inherited myopathies. There is no treatment. And for SMA, for example, there is a gene therapy now. It has been found to be beneficial. The power is improved, has been improved, and even the muscle bulk has improved for SMA. But for this inherited myopathy, still that gene therapy has not come. But for SMA, gene therapy has come. It's very costly. All of you may be reading in social medias how much it will cost in terms of lakhs, 20 lakh, 30 lakh for SMA. The other inherited myopathies, I'll discuss when I discuss the myotonia dystrophy case, probably after another 1 month or 3 weeks in the same